Good afternoon, everyone. We'll just wait a couple of minutes before we start. So good afternoon, everyone, and welcome. Thank you so much for joining us today. We're really excited to bring you this webinar today because we'll be exploring how working together through great collaboration, innovation, and courage can help create positive, safe, and inclusive experiences in sport and physical activity. More than that, we'll be looking at how these efforts can make a real difference in tackling the significant health inequalities faced by people living with severe mental health needs, or SMI, in our communities. Now, this is a big and important topic, and one that affects more people than most of us might think. What we want to share with you today is how partnerships and community-focused approaches can not only improve access to physical activity, but also inform wider policies and practices that aim to reduce health inequalities across the board. So this afternoon, we'll take a closer look at the valuable learning that's come out of a collaboration between the MHIST service at Cheshire and Wirral NHS Foundation Trust and Active Cheshire. Together, we've been working to improve the quality of life for people with complex mental health needs, using movement and connection as a powerful tool for change. So whether you're joining us from health, community, policy, development, or the world of sport and physical activity, we do hope you leave with practical insights and real inspiration for your own work. So let's get started. So my name is Roberta Pomponio, and I'm the Senior Strategic Lead for Physical Activity and Mental Health at Active Cheshire. Active Cheshire is the active partnership for Cheshire and Warrington. In my work, I advocate for mental health to be on par with physical health, and I have a strong focus on system work, prevention and well-being. Jordan?
And I'm Jordan Burrell. I'm an occupational therapist and I'm the clinical practice facilitator in the mental health intensive support team, the MHIST team, which is the service that works alongside Active Cheshire on this project. And alongside my colleagues, I've been involved in supporting the Healthy Lifestyle Coach project that we're going to talk about today over the last 18 months.
So thank you. And thank you all for taking time to be here today. We're really chuffed to see how many people from all over the country wanted to join and hear about our work. Hopefully, you'll find that this session has been planned to fill with valuable insight and practical tips for all of you. In terms of housekeeping, the webinar is being recorded. The recording will be shared with you as soon as it's available. There is a Q&A section. Please use it to ask questions, and my colleague Mike Jones is going to identify questions to share with the panel later on. Sorry, you can also use the chat function to interact between each other. So we're going to start today with an introduction of what are the key players, I guess, in this program.
Okay, so from the health perspective, we work for Cheshire and Wirral Partnership. I'm part of the mental health intensive support team. So Cheshire and Wirral Partnership covers quite a large geographical area across Cheshire West, Cheshire East and the Wirral. And it provides both mental and physical health services and also offers some regional services. So we have CAM services that are offered to the Northwest, eating disorder services as well. And as a trust, we really want to aim to improve the lives of everyone in our communities. We have a set of core trust values, the 6 Cs, and strategically we aim to improve healthcare and wellbeing, work in partnership and within our communities. We want to improve and innovate and also reduce inequalities, which aligns itself really nicely with some of the content that we're going to share with you today. The Mental Health Intensive Support Team, or MHIST, as you'll hear us refer to it as, is a community mental health rehabilitation service. And so we focus on social rehabilitation and recovery orientated care. We have a caseload of individuals with severe and complex mental health needs. You could argue some of the most complex mental health needs within our mental health care system. And across our 3 locality teams in Cheshire West, Cheshire East and Wirral, we serve the whole of the Cheshire and Wirral footprint. I'll let my colleague Amrit tell you a little bit more about the service in depth a little bit later on.
Thanks. And now it's the turn of Active Cheshire. So let me tell you a little bit about Active Cheshire. We are the active partnership for Cheshire and Warrington. We are a physical activity charity and a proud system partner of Sport England. At our core, our role is really to tackle inequalities and that lead to inactivity in our communities. In practical terms, that means focusing on the people and places where support is most needed. And we're working with lots of other partners to create real lasting change. We're only a small team, so we need to work with others. And our role is really to play our part. And that's the name of our strategy, playing our part, which sums up our approach. It is about bringing together inspired and empowered partners, all playing their role in reducing those inequalities and make physical activity more accessible across the sub-region to improve life across Cheshire and Warrington. So today we're going to discuss how we found that there was a need for an intervention within physical activity and patient with SMI within the MHIST team, what happened and what is still happening and what is the impact. We got a really packed agenda, as you can see. I just want to take a moment before we start really with the program take a moment to thank our speakers and the service users who contributed and sharing their stories. They all bring a huge wealth of experience and knowledge to discussion, and I'm sure you will find their perspectives both enlightening and inspiring. So we have now a patient story from one of the patients, the MHIST patients based in Cheshire East. I don't know if Jordan, do you want to say a bit more about this patient before we show the video?
I think if we show the video, so this video has been created by the person. He's had full creative control of what was included. He's included what felt important and meaningful for him. So I'll let him do the talking.
I'd like to welcome Dr. Amrit now to tell us about the background of the program and where the idea came from.
Thank you, Roberta. And just to start off by saying it's really nice to see so much of interest in this, and really welcome the opportunity to share some of what we've learned along the way, and I suppose also what's been achieved. So I'm guessing that I'm preaching to the converted, but I think it's always useful to sort of start saying actually why are the roles necessary. Just to start off, just to say actually what is SMI. So and again, people will know this, but just to emphasize the population group that we're talking about, the term severe mental illness is used to describe people with a group of conditions that are chronic and debilitating, and the ability to engage in functional and occupational activities is often severely impaired. So SMI, severe mental illness, generally includes diagnoses such as schizophrenia, bipolar disorder, and other psychotic illness, and that these which cause severe functional impairment. So that's the population group we're talking about. So I thought it'd be useful to share some figures. These are stark and actually pretty depressing, but it just gives us an idea of actually why is this necessary and what's the work that's required. So this is the life expectancy of people living with serious mental illness. So this has been evidenced in several repeated studies. So people living with SMI face one of the greatest health equality gaps in England. We know that they're twice as likely to experience multimorbidity and develop it earlier than those without SMI. We know that the premature mortality rate is 5 times higher than if someone doesn't have an SMI. And as a consequence of this, the life expectancy is 15 to 20 years shorter than the general population. Next slide, please. I think the big take-home message from lots of today is that actually the premature mortality is preventable. And I think that's the biggest thing. So lots of, so again, these figures show mortality rates for people living with SMI. So again, really stark figures. So there's 6.6 times higher to a higher risk of death from respiratory disease, 6.5 times from liver disease, 4.1 times from cardiovascular disease, 2.3 times from increased risk of cancer, and also they're 3 times more likely to lose their natural teeth. These account for 60% of all deaths of adults with SMI, and again, the main take-home from this is that it's estimated that people with SMI, 2 out of the 3 deaths due to physical illness are preventable. And it's worth thinking about. There's a huge amount that comes in the media and in the press. There's the work's done around suicide prevention. And actually the evidence of how preventable it is it's significantly stronger with physical illnesses. So there's lots of work that can be done with effective interventions. Next slide, please. Again, there's been lots of work done in terms of actually why is there premature mortality. I remember a few years ago when we talked about it was always around, oh, this is about medication, but actually we know medication plays a role. And actually sometimes medication improves the lifespan because people get well and actually can do more. So, but there's lots of other reasons. So access to healthcare is one, underdiagnosis and undertreatment due to diagnostic overshadowing. We know mental illness worsens the prognosis of a range of physical illnesses like heart disease, diabetes, and cancer. They're more likely to have high risk behaviors. The smoking is significantly higher in people with SMI. The drug and alcohol abuse, and also sedentary. The single best modifiable candidate, if you're looking at what can be changed for life expectancy with schizophrenia, is smoking, and for people with bipolar disease is sedentary behavior. Again, I think there's real importance and recognition that actually it's important to have physical health checks, but actually it's not enough to just screen and not intervene. So we need to do both. Next slide, please. This slide there's lots of, if people like graphs, you'd like this, but essentially what it shows is premature mortality with adults with SMI in the Northwest. So as you'll see, if you look at, I suppose, Cheshire East and Cheshire West, actually compared to the national figures, they are in green. But then if you look at Wirral somewhere inside, it's significant. Yeah, there it is. Thank you. It's significantly worse. So. And it's important, I think, to understand actually if you work in a particular population, to understand actually how many people have SMI and try and look at what interventions will work. So it's important to understand the population you're working with and it's understanding how it's best to support and reach them. Next slide, please. Again, this is another slide which shows the link between deprivation and SMI. And not surprisingly, when there's high levels of deprivation, the numbers of SMI is higher, but also the premature mortality is higher. So just in terms of figures, and some of these can be hard to interpret, but if you think about actual figures based on 2018 and 2020 in England, the least deprived areas, adults with SMI are 6 times more likely to die prematurely than adults who do not have SMI. And the most deprived area, they're 3 times more likely to die than those without SMI. So I suppose one of the things which I think is really sad, I think, and is that actually when they've done these studies repeatedly, they've found that actually it's getting worse. So in spite of all the intervention that happens, in spite of all the work that's happening, actually what we're seeing is that the gap's actually getting worse. So I think that's my last slide. Yeah, I'll hand it over to Roberta.
Thank you, Amrit. I just want to take a moment to talk about why the work is so important. Obviously, Amrit has shared lots of data that makes it quick, really obvious. And I wanted to just maybe think about how physical activity can help. So physical activity is a powerful and evidence-based way to counter the risk that have been listed. It supports a healthy heart, it improves metabolic functions, it helps manage the weight. But as most of us know, it goes beyond the body. It also supports our mind. It helps reduce some of the symptoms of depression and anxiety, and some psychotic symptoms and so on. So I think we shouldn't underestimate the power of physical activity normally, but even in this particular case, it is really key how physical activity contributes to great independence and to a clear path of recovery. Obviously, none of this matters if you can't access or can't engage in the opportunities that are available. And this is why we are really keen to promote community-led programs, especially those that deliver peer-to-peer mentors services or lifestyle coaches like MHIST have been able to embed in their pathways. These programs don't just improve the health outcomes, but they help empower people. They reduce isolation. They build trust in the system. So we'll look at the ripple effect of the intervention later on in the afternoon to support these statements. Sorry, I just wanted to also introduce some of the latest, information. So we know there is a growing recognition that physical activity must be a core component of our health and care systems. It's not just a nice to do, an add-in, but it's a fundamental pillar of prevention, of treatment and long-term well-being. You can see on the slide a quote from Paul Corrigan, who is a strategic advisor of the Department of Health and Social Care, that's saying that the NHS needs to learn to work with people around them, so get out of its silo, basically. What does it take really to make this vision a reality? What would a better partnership of the physical activity system with the NHS actually mean? And this is something that we're beginning to see signs of real momentum. So in April, the Active Partnership National Health Conference showcased a presentation by Sarah Price, Director of Public Health at NHS England, and she delivered a clear message that the NHS is ready to be a better partner for the physical activity system, and not only. And so this signals really a shift in the mindset and the opportunities available. It is an invitation really for all of us in the physical activity sector, but for community organization, for physical activity providers, local authorities, public health professionals, to really start working together in a meaningful way with the NHS but in a new and more integrated way. And this can in turn have true systematic changes that reach people earlier, more equitably and more effective. So we're talking about a health equity agenda here. So how do we move then from intention of action? It's good talking about we want to do it and we're ready for it, but what can we do? So the first step in the direction is a declaration that was published by NHS England called Harnessing the Benefits of Physical Activity. And this document basically sets a clear direction. It states that physical activity must become a core part of healthcare, not just a bonus, but a foundation of better health. And you see the four ways to well-being, the 4 ways forward coming into this statement. So we're talking about tackling physical inactivity as a public health priority. We're talking about providing a unified approach across the NHS, about aligning national and local work, and calling for strong partnerships across ICBs, local authorities, and community organizations. So It is a real call for action, and it's showing that the NHS is valuing the opportunity to integrate movement into the way it delivers health interventions. I just wanted to now move on to one of our first speakers. So we have Carrie-Anne Stevens. Carrie-Anne has worked in mental health and fitness, both in the community and non-mental health wards for 5 years. She's most recently founded Mind Body Balance, the Mind Body Balance Academy, sorry, Carrie-Anne, which helps people in the community feel better mentally and physically, working on mental health and recovery journeys through community support, movement and mindfulness, whilst offering pathways to more traditional therapy services. It's been a very brave decision that's paying off. It's a really successful hub for the whole community. So I'll let Carrie-Anne tell you all about her work. Thank you.
Yeah, thank you for that introduction, Roberta. You've clearly laid out everything that we're doing at the hub, which is fantastic. Yeah, I was very lucky to start working with Roberta a few years ago and to work on the wards, which gave me real insight into what we needed in the community. It almost felt like we didn't have enough choice in communities for people to make their own judgment about what they needed. And so when I set up Mind Body Balance Academy, I did that so that people had a safe space. I know that we offer gym memberships and different activities, which is fantastic. But sometimes if somebody's feeling so unwell, they're not going to want to go to the gym. I mean, I don't know about you, but sometimes I don't want to go to the gym, and that's on a good day. So, and so Mind Body Balance was created to give people pathways. So somebody who doesn't want to come in and do exercise will build a community and go on to do some meditation, and then they might feel well enough to do some one-to-one work with me, and then they might go on to do some more group sports. And what we're seeing is that pathway is really working. So we work in contact with the MHIST team. They sometimes bring people to us who can come and see what we've got to offer, and then they make a choice themselves about what they want to attend. And we've noticed that it's never going to be one size fits all, and that the connection with who they're working with is essential. You've got to build those relationships to ensure that people feel safe to come into the environment, and then take that brave step to maybe move into, we're doing paddle, boxing, you name it. We've got lots of different things going on, and people are actually coming into us now and saying that not only has it improved their mental health, but they've actually come out of social isolation, which is another knock-on effect of severe mental illness. They are building new networks in a healthy way, so they are incorporating sport in their weekly routines, which is giving them a new outlook. And what we wanted to really focus on was making sure that we didn't lose people along the way, because it's really difficult if you have a week where somebody can't get out of bed or they feel severely unwell, for that to turn into 2 weeks of no activity, 3 weeks of no activity, and then we're losing people very quickly. And so the programs that we've designed ensure that we give them hope. So we're not saying you can't get out of bed today to come and move with us. Can you do some journaling? Can you come to meditation? Can you come and sit in the space and just be there and be around people? And we're really seeing that with those extra support areas in place, it is really encouraging people to stick with us and then get through those difficult phases and keep going in the direction that they need to go for their physical and mental health. One lady in particular, which I will talk about, came to us, and she came to me on a one-to-one basis. And she was suffering from severe mental illness and addiction. And she came in for the first session for weights. We did some weight strength work with her because she was very severely depleted in her strength, because when she, obviously we're not moving, we're losing muscle. And we talked, I think for the first 3 or 4 weeks, we talked and we didn't move much. And that was fine, and then there was less pressure. And then she came in again and we did some more strength work. And then she felt safe to see some other people in the space. And now she attends paddle and boxing. She's got a new support network, and she knows that she can come to us whenever she feels that she is having a bad time or a low day. And we can always pinpoint where we need to send her if she needs more help. So it really is a big package, and I think it would be wrong for me to not touch on the cost implications of offering this. I set up Mind Body Balance Academy because I thoroughly believe in what we're trying to achieve, and I've saw the gaps, and we're trying to plug those gaps, but it costs a lot of money to deliver those services, and we are working on a pay what you can basis at the moment, and it's working, and we've got some investors that back us to help us keep going. But I think to remove that barrier of cost is essential, because people aren't going to be able to afford to do 3 or 4 physical activity a week. It's costly, isn't it? And so, we're really lucky at the moment that we can keep that going and that we have that provision in place. And I just hope that we can continue to do that with the support of the NHS and other backers once we show that what we're doing is working, which it really is.
Thank you, Carrie. Sorry, I couldn't find my microphone to unmute myself. Thank you very much for sharing your point of view and your experience. I think is really helpful to give us understanding what is available in the community and how you approach this. I'm going to hand over now to Dr. Shetty again. Let me put the slides back on. Who is
Thank you. Thank you, Roberta.
Okay, who's going to tell us all about the background to the actual project.
Thank you. So I suppose this is the detail of the actual project and what we did. So just really briefly, and Jordan touched on this in terms of what MHIST do. So MHIST is a community rehab team, and it, as Jordan said, we work across Cheshire and Wirral. So we are a fairly new service. So we've been around for about 2021, so around 4 years. And we were set up to work with people who were considered as really complex. So I think particularly for this talk, it's important to understand the context. So lots of the people we work with had been in hospitals for several years, haven't lived in the community at all. And even if they had, they'd been quite seriously ill. And it was seen, I think we were, the main focus of this was to see actually can we work with these individuals in a social rehabilitative way to see how we can integrate them back in the community and support them to have meaningful lives. The MHIST team does have 2 functions. The function I've just described is the intensive support function in the community. And this intervention particularly focuses that group of patients. But we also have another arm, and that looks at people who are in out-of-area hospitals. So there's a small proportion of patients who are in different out-of-area hospitals, and we support them too. This intervention particularly doesn't focus on them, but I suppose it's worth keeping in mind that actually, in terms of their physical health, when you're locked up in hospital for years, it's what happens, and actually how can we continue supporting them. So next slide, please. In terms of the background, I think we were aware when we were coming together that actually there was a very high levels of physical health illness within the patient cohort we're working with. We knew that again with the evidence that I previously talked about, the single most cause of premature mortality was physical health. We also knew that there were lots of services that were around, but actually our patients were struggling to access them. So some of the services were set up for people with less severe mental illness, and it required certain levels of engagement or to be more well. And actually, our patients just didn't fit that cohort of sort of that cohort or that kind of requirements, inclusion criteria. We were a new team, and we were just setting up. We started off in Chester and then spread across Cheshire, Wirral, and then Cheshire East. And the team were all new, and we realized we actually don't understand what's out there as much. So we knew what was within CW, the Cheshire and Wirral Mental Health Trust, but we were not fully aware of what was out there. And we initially had this sort of plan of trying to set things up ourselves, and quickly realized that actually it's not possible when we're working across such a wide footprint. And we were working with a very small cohort of patients too. And then the team was very good clinically. There was a huge amount of expertise, but actually we realized actually couldn't fulfill the goal, which was actually improving quality of life and providing holistic social rehabilitation with just clinical skills. We need a lot of partners. I suppose that was a background, and we very quickly realized the team was becoming very much a clinical team unless we did something different. So I suppose that's where some of the ideas came from. So, and also in terms of the national and regional context, as people be aware, we've been going through a community transformation, which is a national drive, and so we were linked with some of that. And there's a real focus on ensuring that actually it's holistic transformation. It's not just about mental health, but actually how do we improve physical and mental health, and there's a real focus on being more integrated. And working with partners. So I suppose that really helped us. As part of that, CWP was working with Rethink at that time, and one of the leads, Mark Treven, sort of got us in touch with Active Cheshire, and I think that's how we met Roberta, and started exploring some of the ideas of actually what would that look like. Next slide, please. So I think in terms of the aims, and I'll go into some of the details of what we did, but in terms of the aims, it was really about actually how do we embed physical activity into MHIST to enhance mental and physical health outcomes for individuals, and integrating sustainable physical activity interventions into the support plans. That's a mouthful, but I think what we were trying to do was we didn't want it to be as a we'll do the mental health stuff and then we will do a little more. It was very much meant to be the offer had to be in-house, and it had to be something that was part and parcel of what we did every day. I must say, when I started off, we were really focusing on measurement. Let's just measure. And I think this is one of those pitfalls. Let's measure and look at how we can treat side effects. But actually, we realized very quickly there was much more. So that the partnership was really focusing on, and there were 4 key objectives in terms of what we want to try and do. So it was connecting clinical and community resources, and we were looking at creating connections and to link clinical services with community offerings and showcasing existing opportunities. For example, one of the things which I remember right at the start Roberta did was organized an event where a number of different providers came. I think it was in the local sort of next to the police station. I can't remember what it was called, but it was great because we met so many different people there. There was the Fallen Angels, where they were talking about dance and how that helps with mental health. There was the Boulder Hut, I think it was called at that time, climbing hut, I think. So there was that, and there was all kinds of resource and all the kind of stuff which we were not aware of at all at that point. And what was really helpful for us was that connections and understanding actually what's already out there, what's all the kind of stuff that's already happening. And there's much more, I suppose, from my perspective, much more than just gyms. And I'm not saying gyms are, it's not good, but I suppose lots of our patients actually went ready to go to a gym. And that was, I suppose, that was one of the objectives of that. Something about baseline measurements, and we were keen, I suppose, to try and take a quality improvement, understanding actually what is it that we're focusing on. It wasn't just about people losing weight. It was much more than that, and it was actually trying to understand physical activity. And we did some. There are lots of measures out there, and we did some work trying to sort of see what would help. And so we did lots of baseline testing in terms of trying to say actually what should we focus on. The other bit, which is what we're focusing on a lot, is actually implementing implementing well-being coaches. So the resource we made this a key role within the team, so that became a part of the team, and I suppose we developed a job description for this, and we employed, or we got a job description ready for 3 well-being coaches to support individuals in the community. And the idea, and again, I think we'll talk more about that, my colleagues will, was I suppose it's really how do we make that as a regular offer, and actually having experts within the team would help build that bridge between community resources and what we do on a day-to-day basis. And then it was around physical health activity interventions. It was rolling out targeted physical activity interventions in specific areas and partnering up with different sort of offers that's already there. As I said, there were 3 health lifestyle coaches that we employed, and then Active Cheshire helped support sort of bids for capacity to set the service up and start the process. Next slide, please. It may be my last slide. Oh, no, there's one more. So the desired outcome was to work towards providing safe and friendly environments with anyone living with a mental illness that can access physical activity and a healthier lifestyle, and at their own pace, forming part of the pathway towards positive mental well-being. And these were some of the key outcomes, and that aligns with what the service was meant to do. It was aiming at reducing hospital readmissions and improving quality of life. It was increase physical activity levels and retention, integration of physical health well-being coaches into the team. And if I'm honest, this was harder than I thought it would be, because actually it was really, really different from what we were used to. And having someone with no mental health. I suppose it wasn't a prerequisite to have any mental health experience at all, and actually think really differently was difficult, but we've learned a lot from that. And it may come up with the questions later on, but there was a huge amount of learning for the team, and but actually how does this work together? So that was part of the key outcomes we're looking at, and is to develop protocols. And I suppose this is part of what we're doing today, trying to really think about actually what does that mean in terms of if someone else had to try something similar, what does that mean, and how do we work? I suppose how do we produce wider system change? So that was, I suppose, something we were quite keen on right from the start.
Thanks, Amrit. I'm going to talk just quickly about some of the more practical outputs of the collaboration. So you did mention creating connection, which was a mini event, and I think that's where we met Carrie-Anne for the first time as well in a community setting. So the idea was to get you all out of your hospital into the community to speak to people and providers that offer from dance to climbing to martial arts and whatever, and walks and whatever else. Because we're a charity, we also have that flexibility that the NHS doesn't have. So we were able to apply for a small amount of funding, which helps us support the healthy lifestyle coaches in the first months of their work. So we use the money to deliver some, to invest in some small intervention. So for example, we purchased some upcycled bikes, which enabled some of the service users to become more independent because they were able to cycle to whether it's the hospital appointment, volunteering, or work. We did work really closely with the Mental Health Alliance, which is based in Cheshire West Voluntary Action within the voluntary sector. We bought some passes for Delamere Forest. We're very lucky that we have one of the national forests nearby, and the forest has been used for spending time in green space, which offered benefits both to the service users and the staff. Buy some activewear. We spoke about the financial constraints for some of the patients with SMI, but some people didn't have the kit to go to the gym or to go for a walk. So we bought some shoes, we bought some jackets so that they could access the activity they wish to do. But at the same time, we commissioned a pilot with Cheshire Mind to deliver an intervention for people with common mental health, and they delivered a 5 days program around the 5 ways to well-being, showcasing physical activity and its benefits and connecting with the local providers. And we also commissioned a report to on personal health budgets to Disability Positive, and Annette will join the panel later on about it. This is we identified that there was a bit of a gap in the uptake of personal health budgets with in section 117, and Annette helped us explore that opportunity, and we're now working on hopefully improving the uptake. And again, as Amrit mentioned, we helped we supported with the recruitment of the healthy lifestyle coaches, the development of the job description, and the initial introduction that some of them needed with the providers in the community that we as an active partnership were more familiar with. So this is some of the sort of practical outputs of the initiative. The project is no longer a project; it's now embedded in the team. So the MHIST team and the healthy lifestyle coaches are carrying on without Active Cheshire, but it's nice to keep in touch with them and see how they're progressing. We're moving on to another patient story. I think these are wonderful, and they come all from some of the healthy lifestyle coaches patients. So, Jordan, do we want to introduce them, or do we just play it?
I will just let you know that so this is an individual that's worked with Nigel, who you're going to hear from in a little while. The sound quality, it can come across a little bit quiet, so hopefully you are all able to hear. Fingers crossed it'll be on the recording anyway, and you'll be able to listen back if you wish to. But I'll let her do the talking. hopefully you could all hear the really meaningful and valuable impact that support and intervention has had on that individual, and how it's really helped them enhance their quality of life. And the OT in me is like, oh, look at all those meaningful occupations: horse riding, skiing, cycling, building strength, working towards their goal of walking. So for her, it's really evident that that's been really, really life-changing in lots of ways. And on that note, I will hand you over to Nigel, our healthy lifestyle coach in the Wirral MHIST team, and Sonia Carty, who's the health development officer for Active Wirral, and they can share a little bit more about the collaborative work they've done together.
Thanks, Jordan. So my name is Nigel Richmond. I'm the healthy lifestyle coach on the Wirral with the MHIST team. I want to talk alongside Sonia about the collaboration between the MHIST team and Active Wirral. It was something that I was really passionate about when I first started in the role, with minimal mental health experience, really. I worked in primary care for a couple of years, but prior to that, close to 30 years in the health and fitness industry as a trainer and a coach. So I was very kind of keen to build a relationship with as many third-party organisations as I could within the Wirral, to give that positive environment and the positive service provision from those organisations. If I can hand you over to Sonia, who will tell you a little bit about how that collaboration came about.
Hi everyone, Sonia Carty from Active Wirral. Just a few points really about our collaborative work with Nigel, which has gone really, really well. So 2022, NHS Health Coach and Active Wirral relationship we established while setting up a wellbeing walk and receiving support in related training and marketing. So we have a lot of wellbeing walks. We work with the Ramblers, so we partnership with them, and we are able to offer these walks across the Wirral, and they are also for free. So we use our communications lines and try to push that out as much as we possibly could, and they're very, very effective, especially for those with mental health issues. It's not just about your physical health and you walking and you getting your steps in, but it's also about being able to walk and talk and open up to people. Walking side by side someone is often more effective because you're not under that pressure of eye contact, etc. So we find it incredibly beneficial to do that. We also developed Nordic walking from there as well, which is also free across the borough. September 24, MHIST and Active Wirral project set up to allow patients access to Bidston Activity Centre for exercise induction, programming and one-to-one instruction and support. So I think really important, my relationship with Nigel goes back some way in his previous job roles, which is always concentrated on health. And when he was so passionate about this and helping people, I was really so passionate about finding a way to help Nigel with his patients rather than finding reasons not to do something. It was super important that we found a way. Nigel came into the gym with some of his patients, and it's a quieter time of the day was always beneficial. So that sort of created a kind of neutral therapeutic atmosphere where people didn't feel the pressure, and they didn't feel like everyone was watching them. It was quiet. We turned the radio down or off, and it was really important to create that atmosphere that really helped. Interventions included coached use of the gym facilities and physical health consultations to goal plan with Nigel. It meant he could go at the pace of those patients, and I really went some way to convince management of the leisure centre that it was important to take our time and not, you know, give Nigel only 6 weeks to help someone. It was going to take as long as it needed to take for something like mental health issues. No one person is the same as another, so it was important to take the pressure off, remove those barriers as early as possible, and increase the knowledge and confidence and empower that patient. We could have had people who had had a bad experience at school or hadn't done any physical activity for many years, so they might never have been in a leisure centre in their life or not been in for many years. So the importance was about allowing Nigel to handhold them as much as they needed and bring them into that gym environment where they felt safe with a familiar face such as Nigel. I was around now and then, so they could see a familiarisation as well. And then those patients, when they felt familiar and had potentially finished their road with Nigel, we would then welcome them into our We Are Undefeatable health referral membership, which is heavily subsidised for those with long-term conditions. So this improved incredibly beneficial for those people, so they could see a way forward rather than from discharge to nothing. We meant the next steps was about moving them forward for their longevity and the help we'd given them with behaviour change, etc. So the next steps forward, we're hoping that we can actually spread this project. We have 6 leisure centres, 5 of them have pools, and so it's about helping those people where they are at, finding some kind of physical activity intervention that they find they enjoy. If we find that for them, the chances are they're going to keep it up and keep enjoying themselves and moving forward. So I would like to think the next steps for myself and Nigel to sit down and talk about is spreading this throughout the rest of our centres. This was a pilot, it's gone so well that I think it's a natural move to include all the other leisure centres.
Thanks, Sonia. Yeah, so what I thought I'd do, just spend a couple of minutes really talking about how the collaboration between MHIST and Active Wirral worked in reality for a particular patient. So I've chosen a patient called Oz, who was a young man with a diagnosis of paranoid schizophrenia. He had mental and behavioural disorder due to sort of prolonged use of cannabis. He did have a history of aggression and violence as an inpatient, and when he was discharged onto a community treatment order in April 22 with the MHIST team, he initially went into supported living accommodation. But with the work that the multidisciplinary team were doing with him, he very quickly moved on to independent living. Oz spent 2 years with the MHIST team, and it was the last 6 months that I was fortunate enough to work with him. The sort of summary about his health and lifestyle at the time that he was discharged onto the community. He was a regular cannabis smoker, and he also drank quite heavily, and we find this is quite common for people dealing with sort of schizophrenia and dealing with voices. Although he was discharged onto the community, he very much isolated himself. So he spent a lot of time in his accommodation, and his health suffered as a result whilst in hospital and in the early sort of months on the community. So he was obese. He did have a stage 2 hypertension, so he had raised blood pressure, an irregular and poor diet, no more than 1 planned meal daily, and sometimes not even that. Oz did have a lot of positives. He had a good insight into his condition. and he had a lot of past positive experiences, boxing, running, and he had some experience exercising at home. So it was to capitalise on that, really, and to capitalise on positive past experiences that was the strategy, really, for him. Next slide. So a lot of Oz's physical health goals are some very familiar ones that we see all the time. You know, he wanted to lose weight. He had a good insight into his what he wanted his physical performance to be like. He did want to, you know, substantially increase his fitness and improve his body image. He had quite poor body image and low self-esteem at the time. He wanted to raise and regulate his mood and improve his energy stability, and to increase that self-esteem and confidence out in the community and in those different environments. So part of building his confidence was he sort of stressed that although he'd trained in the past and he trained for a long period of time and exercised with boxing and running, he didn't really know how to approach it this time around and what to do. And when I initially found him, sort of started working with him, he was quite isolated, and he was using activities that sort of kept him in his flat alone or running along the road with his headphones on. So I was quite keen to sort of work towards a more sociable environment for him. Next slide. So the interventions we worked on, and obviously I've got Active Wirral to thank for providing the facility and the environment that we used. My background was in personal training and group exercise coaching, along with other things. So it was a chance to really kind of put together a specific program for him, something that was a bit more balanced, a bit more periodized, give him a little bit of understanding of different modalities of training. Not always high impact, or he tended to just go running and run at the same intensity and just try and run further and further every day. And he did comment that he was suffering with a number of injuries. So it was an attempt to kind of give him a kind of more balanced approach with his training and develop his confidence. The one-to-one instructed training sessions were essentially personal training, you know, that he could capitalize on with myself. And this allowed us time to build a broader understanding and develop the confidence. I think the importance was that I worked with him on a one-to-one, gave him plenty of time to build confidence in his physical ability and an understanding of technically how to execute exercises, and it seemed to stand him in good stead. We also used other areas of the leisure centre, because it was a really positive, quite a bustling environment out in the social area in the cafe. So we did a lot of dietary discussion and very gradual sort of work on encouraging us to fill in a food diary and complete sort of a bit of meal planning during sessions. And I was capitalizing on the endorphin, you know, of him exercising and being in a really positive frame of mind. Monitoring his body composition was quite powerful. Using the Active Wirral's track app, he was able to be much more engaging and much more health aware with regards to visceral fat and hydration, and not just focusing on weight alone. Other third-party organisations that I've had a chance to work with, one of which very similar to Bren Cycles in East Cheshire is Energize Cycles on the Wirral, and they're a local community enterprise company that provide cycling instruction courses to train cycle leaders. They provide workshop, the chance for special populations, sometimes people who've come out of prison to engage in group maintenance workshops where they're working on their own bike. They do work with the blind and take a group of blind people out on tandems. So they do a lot of work, and I've been lucky enough to sort of build good relationships with them, and that really helped us sort of start accessing exercise facilities, and in particular Bidston. He was able to then access Bidston on his own, using his own transport and cycling there. So Oz, the success story really is he moved from a very self-isolating routine, running on his own, to understanding a sort of more structured approach, and became very confident. Started to build confidence in terms of his body image, but also it was a slow transition, and coming out of hospital, he sort of built confidence within the environment, and became quite comfortable working alongside, obviously, the other gym users. Oz confirmed a gradual move towards. He basically gradually moved towards more whole foods, and started to plan meals much more in a much more structured way. He lost weight, although we always hear, we always talk about weight not being the be all and end all, but it's generally a good measure if it's a gradual approach, and if there's healthy intervention coming across. And speaking to Oz a couple of days ago on the phone, I was really pleased to hear that he was able to continue a lot of these positive lifestyle changes. He's continued to lose weight down to 26 body mass index, and really kind of has kept some good habits. And I think the most important aspect for me is his level of confidence. He was able to access education, so he's done a couple of IT training courses, and he's now volunteering in a boxing gym, where he hopes to become qualified in his fitness qualifications, and as a boxing coach as well. So that was really pleasing. I'm wondering whether Sonia has got anything else to add, or.
No, I think it'll come up later. Just the fact that the partnership working was so good, that we managed to almost put a team around ours and help him in lots of different ways. So and well done, Nigel, in leading him through that.
Yeah, great work, and it shows how much the person-centered approach is important with these patients, and it's got to be really intervention is to be bespoke with them. Thank you, Nigel and Sonia, for sharing your experience. Jordan, it's up to you now to tell us all about impact and outcomes of the program. Thank you.
Wonderful. Okay, so as hopefully you gathered, we're really lucky in our service to have these healthy lifestyle coach roles. These are permanent full-time roles within our service, and we have a healthy lifestyle coach based in each of our 3 locality teams across the Cheshire and Wirral footprint. So over the last 18 months, I've been working alongside the healthy lifestyle coaches and the service, the MHIST team, to help embed the role of the healthy lifestyle coach into each of those services, each of those parts of our teams. I think one thing that's worth noting, and I think is a real a really wonderful aspect of the coaches that we have in our roles is that they're all really different, and they all have different backgrounds. They all have different interests. As Nigel mentioned, he's not got a mental health background. You know, he spent his career kind of working in the fitness industry. So they all have different interests, different ways of working. So whilst the roles are the same and the structure of the roles the same, we really get the benefits of having their individual experience and then bringing that into our teams and into our roles in each of the different services, which I think is really wonderful. And kind of a testament to the individuals behind the roles. So how the role works in reality is that our healthy lifestyle coaches are integrated into each of our multidisciplinary teams. So they attend the weekly multidisciplinary team meeting in each of the locality teams, and that really is the pathway into working with the healthy lifestyle coach. So they work directly with a small caseload of individuals. And I guess one thing that we're really mindful of is that they're a limited resource. There's only one of them. And for kind of context on numbers, as a service, MHIST is commissioned to support up to 75 people. So that works out roughly to about 25-ish in each of the locality teams. So we know that one person on their own can't support every single one of those 25 people. So we kind of acknowledge that they're a bit of a precious resource in our team. So they work one-to-one and directly with a small caseload of individuals. And generally they're people that have identified goals that are related to their physical well-being. And aside from that, in that MDT space and in discussions within our our team offices, they can offer advice and guidance for those that they're not working directly with. It's interesting because as part of pulling this together, I've been reflecting on some of the learning, as Amrit mentioned. You know, it's been a real process of kind of learning throughout. And I think one of the initial visions is that some of the interventions might need to be more time limited because we've got a limited resource and we want to be able to kind of spread that as equitably as we can across people that might want to access it within our services. And for some people that's been okay, but actually for lots of the people that we're supporting, they've needed a bit more time to build relationships and to actually work out what their goals are and to go from where they're at, which is often, you know, maybe quite isolated, maybe not leaving the house. You know, the kind of the stories that you've heard from the patients and the people that we're supporting, the point that they started at is that they weren't really leaving the house. They weren't really going anywhere on their own, and they weren't really engaging in a lot of physical activity. So actually, in order to sort of support and create an environment for change, that's taken quite a bit of time, and it's taken a lot of relationship building, and it's taken a lot of going back and working through, okay, right, what's your next goal, and when we get there, you know, how are we going to get there, and what do we do next? But that's been really lovely to kind of see, to have the privilege of being able to see that grow and develop and see some of the really wonderful, meaningful work that's come from that. Our healthy lifestyle coaches also support with completing biannual health screenings. So guidance recommends that everybody with an SMI is offered an annual health screening. So we're trying to kind of keep a bit of a closer eye on that. We did initially, again, thinking about learning, we did initially try to review people's physical health screens every 3 months, and I think we fairly quickly realized that was probably a little bit ambitious, and we don't really want to be screening people unnecessarily. So we offer a biannual health screen which people have the opportunity to opt into, with a goal of hopefully helping them to work towards accessing that through their GP, because that's where they would access it when we're not involved as a service. The healthy lifestyle coaches also act as a really wonderful bridge between our service and the people that we're supporting and local community resources. So Nigel's already talked about the collaboration with Active Wirral. We've had links and collaborations with Brio and Everybody Health, so the other kind of leisure providers in Cheshire West and Cheshire East. And Roberta's also mentioned Bren Bikes and Delamere Forest. You know, we've been really fortunate to have access to additional resource to help us support people and reduce some of the barriers to accessing movement and activity, whether that is gym-based activity or just kind of getting out the house. And we also, one of our visions is that the healthy lifestyle coaches have a bit of a role in helping change us as a staff team and support us as a staff team from a health promotion, from an encouragement point of view, and I guess it's really about creating a culture where physical activity is important and movement is important. And I guess speaking from my own personal experience, I've found it really inspiring and encouraging to work alongside our healthy lifestyle coaches. And I know as a result of that, I've made various changes in my own life to be more physically active, which I get to experience the benefits of. And I've felt really motivated and encouraged by their passion, by their enthusiasm. I guess some of the things that are kind of ongoing, because as we've said, this is a process of learning, and these roles are, they're still relatively new. So I guess there's still areas of development around how do we connect more with primary care networks? How do we make use of things like personal health budgets and personal assistance, and how do we really capitalize and maximize what's available and the support that we can help get in place for people, so that when they're moving through our service into back into kind of secondary mental health care, or maybe they're just under the care of the GP, that they can continue making these changes, because it's all good and well them doing it while they're under us, but this is about long-term sustainable change for people, and how we can really help people set themselves up for lifestyle changes that will see them through the next 5, 10, 15, 20 years. And hopefully that's where we see the most impact down the line, when people's health is better for longer. I guess people are probably sort of interested in data collection and outcomes, and this is something that we've had a bit of a challenge with, really, because our electronic patient record system has barriers to pulling data and allowing us to audit that very easily. I started trying to do a manual audit, and it was just a big old job. And I'm an occupational therapist. I'm not a data analyst. It's really not my strong suit. And I guess one thing we've also sort of recognised is the element of objectivity that comes from kind of self-rated or kind of clinician-rated health indicators, which might not always give us the most accurate or consistent picture. But in terms of some of the data that we did have, I pulled a sample of data, and actually when we look at things like BMI, it told us that there were some changes, but maybe not huge changes. So we noticed that in this sample of individuals, the BMIs that were 30 plus, so kind of classed as obese, were fewer. The BMIs of 25 to 29.9, which is overweight, there was more of those, which would indicate that the people in the 30 plus category have hopefully lost weight, but it might also indicate that other people have put some weight on. But it feels important to acknowledge that whilst BMI is part of the Leicester tool, it's in the guidance as an important health indicator. It's also can be a flawed indicator in some circumstances. So I guess one thing that we thought was really important to consider is how we think about the outcomes and the interventions holistically from a really person-centered point of view. So objectively, what we know and what we see in our day-to-day practice is that those that are engaged with the healthy lifestyle coaches, regardless of whether their BMI changes, whether they gain weight, lose weight, whether their activity scores change, they're generally more actively engaged in meaningful active occupations, which is a wonderful place to be starting from. And I guess we know that the healthy lifestyle coach role adds a valuable contribution to that person's recovery, and whatever that looks like to that person. And I guess how I interpret this is that has real power to potentially influence longer term change in a person's quality of life, as we saw in the case of Oz that Nigel shared with us. Actually, a year later, those lifestyle changes are sustained, and hopefully will continue to be sustained for many more years to come, which we know will ultimately then have an impact on his overall health and well-being. So again, just to share some more experiences from the people that we support who've really, really graciously allowed us and consented for us to share some of their experiences. So we have a chap here who is under our Chester team. And as we can see, he's been doing some gardening. I'm not 100% sure whether this bike came from the Bren's Bikes collaboration. I think it might have done. He's been accessing Delamere Forest, which again, we got access to some Delamere Forest passes. So that's made that more accessible because the parking can be a little bit expensive at Delamere Forest. So there's a couple of quotes there that I'll allow you to read. But ultimately what he's saying is that he's doing more. He's going to the gym, he's getting out and he's engaging socially. He's going to the shops and he's been making more health conscious meals, all things that he wasn't doing before. and he's socializing and he's feeling well. Ultimately, that's probably the most important thing, is that he's stable, he feels stable, and he's enjoying being well, which we can't really ask for more than that, I think. You can move on to the next one, and here he is on top of Frodsham Hill. I don't know if anybody's familiar with Frodsham Hill, but it's a bit of a hike up there. It's quite steep. It's definitely a bit of a workout. So yeah, he's been able to access those alongside Kate, our healthy lifestyle coach in Chester. And if we move on to the next one, Roberta, another lady that's been supported by Kate in some more kind of, I guess, holistic activity-based interventions, particularly around gardening. So I think what she really emphasises is this holistic approach to mental health, which she's never experienced in her many years of being a patient. So she's now going swimming, she's going to the gym independently, she's building more of a positive routine around her depot day and kind of helping support herself in that way. And she's gained new gardening skills, which she talks about with her sister, and that's really helped with supporting and strengthening their relationship. And she's got an allotment that she can enjoy with her family. So whilst these might not be kind of traditional exercise, actually it's getting people out of the house, it's getting people outside, it's getting them moving, which ultimately really contributes to their recovery, and then building a meaningful life that looks good, looks and feels good to them, which I think ultimately is the most important thing. And, you know, our overarching goal as a service is we want people to be living a good life that looks and feels good to them. If you move on to the next slide, Roberta, I think I'm finished with that bit.
You have indeed. Thank you. You've done a great job in providing us an overview of the impact that the work of the coaches have had on the service users. I think it's, I'm not a big fan of data, and BMI is great, but hearing that some of the interventions change the attitude to life of some of the patients that were isolated are going out now, taking part in community activities. I think it fills my heart with joy, to be honest. So yes, all the work that you and the team have been doing is exceptional. So thank you for that. I'm going to ask my lovely panel to put the cameras on now. So we've got some questions prepared for Amrit, Jordan, Annette, and Sonia. And I noticed there's a couple of questions also that have been appearing in the Q&A in chat. So I'm just going to take this off so we can actually see each other. And I've got a couple of questions prepared, as I said. So just to find out a bit more about what your thoughts are on sort of working as a system. Sadly, we can't clone Amrit and Jordan and Nigel and Kate. So I think the real way forward for this type of intervention is working better as a system. So we do talk a lot about system change. What does that mean to you in the context of reducing health inequalities for people with SMI? Who wants to start?
Should I go first? And I will be brief. I'm aware we're slightly over time. So I think for me, and there's lots out there in terms of, I think, some of the work that's been done. But for me, I'm just listening to people speak. I think lots of this is about hope and integration and collaboration, I think. And I've been a psychiatrist for a number of years, and I think some of the things I've always heard is actually we don't believe some of the patients can do a lot. Sometimes I think we don't have enough hope. And for me, I think what the system change starts with that. It's I suppose believing that actually this level of change is possible. I think it's very much about collaboration too. Everything that was presented is all about actually if we try to do this on our own, and we did try for a little while, if I'm honest, it won't work. It's very much actually how do we work, and there's so much out there. There's so many resources other than I suppose statutory services. It's how we work together. And again, I think there is a recognition. I think there's an increasing recognition that physical health and mental health go hand in hand, but I think there's a huge amount of work to be done. It starts with culture change, and I think webinars like this are absolutely brilliant to sort of start thinking differently.
Thank you.
I think I'll pause there. I can talk a lot about this.
Anybody wants to add anything on this?
I think oh, sorry, Annette, did you want to come in?
Yeah, I was just listening to what everybody was saying, and take from a physical impairment point of view where somebody needs physiotherapy, and basically they'll get professional physiotherapy for up to 12 weeks and then it's reviewed. But alongside that, a personal assistant is working with that physiotherapist to learn those skills in order to continue that after a period of time. And maybe that's what needs to happen. I think I get a little bit tired of looking like a gym membership or other exercise classes as being a leisure opportunity rather than a therapy, if you know what I mean. So it's always classed as that when I'm doing personal health budgets, but we don't pay for activities. But maybe we need to look at it differently, because to people, you know, who are eligible for Section 117 funding, basically that's exactly what it can be used for, really, to me, to continue that throughout their period of support and life.
Yeah, thanks, Annette. It is a really helpful tool, isn't it? The personal budget that can help sustain this intervention with people with under Section 117. Jordan, so you were going to say something.
I guess I was just going to say, talk about the value and the importance of amplifying the voices of the people that we're supporting and really hearing them, and meeting them where they're at, and working with them in really recovery orientated and person focused ways. So really thinking about how are we alongside this person? This is not about pushing them down a path that we think is the right path for them. It's how do we help them work out where they want to be and think together about how we're going to get there, and help them take more ownership of that, and to have that for themselves.
Yeah, thank you. I'm going to come back to you, Annette, for another question here. From your point of view, what barriers have your clients at Disability Positive encountered when they're trying to make choices about their own ways of thriving and living a positive life through community-based approach? How easy or difficult is it to access the funding for what people really want and need?
I think the barrier can lie sometimes, you know, from the ICB themselves and how they deliver it, that basically it's at times very prescriptive, that basically it can only be used for personal assistance, which doesn't quite work for, you know, this client group. It doesn't work that they need personal assistance all the time. And not looking at it being a personal health budget is an amount of money for that individual to use the best way that they feel meets their outcomes within a support plan. And quite often we'll get from the local authority that the activity is in there. A gym membership will be mentioned in there. But when then you come back to health, it's like, no, we don't cover activities. They get PIP or they get benefits. Well, not everyone, you know, does get PIP, does get a mobility component of PIP. So it's quite difficult financially. I think it's a little bit of finance for them to fund it themselves, and also have to fund a carer to go with them on transport, because in Cheshire we don't have a +1 bus pass. Quite often people eligible for Section 117 aren't eligible for a disabled person's bus pass. So you can look at it all. You can look at it, it's the money, it's the transport, and it's the way that personal health budgets are being delivered at the time that we did that report. But I have to say, the bulldog in me has made those changes, and we are now seeing referrals for personal health budgets that are purely activities.
Brilliant.
Yeah, and if somebody needs a personal assistant to be with them on those activities, to accompany them at the time, then basically, as I think most of you will know, we do work with the activity providers in saying that an assistant will go free to be able to do that. So things are changing, but very slowly. I think since we've done this, we've still only had 2 referrals. So we need the referrals. People are not being referred. And it can also be a transition from hospital to the community, where a personal assistant is actually going into the hospital as part of that transition back into the community, and they start there as well. So it's looking at being that normal thing of thinking of personal health budgets when somebody's being discharged, because we still have a very small amount of people accessing personal health budget.
Yeah.
I only know one on the Wirral. And yeah, so I think we need to.
Yeah. So what I'm hearing also that there's a gap in the knowledge of the workforce within NHS in realizing that this is a resource that's available, and maybe there's something that needs to be done about that. That sounds great.
Yeah.
Thank you. Yeah. Thank you, Annette. Sonia, quick question for you from the, I guess, for the point of view of a leisure provider, a large leisure provider. What does the effective collaboration work across different sector, health, physical activity, local authorities, etc.? How does it look like, and how does and what drives change? We're hearing a lot of good things coming from the Wirral. What can we learn from the Wirral?
Yeah, so it's kind of a big question that I think a lot of it's to do with relationships. It's about putting the energy into those relationships and nurturing them. It takes time. And you know, it's a cliche, but things move at the speed of trust, and building that trust is you know, the way to go, and has the most powerful outcomes. Obviously it's got to be a mutual beneficial partnership, and it's about looking at culture as well, changing the whole leadership system. And you know, I'm very passionate about this work, but as you said earlier, if I'm not here, how does that carry on? So I nurture relationships, but also involve as many people as we can. We, as a local authority, we spend a lot of time in the VCFSE space. So you know, the CICs and the charities. We play a big role in the local communities, because I think that's where a lot of these answers come. It's about asking people what they need and what they want, rather than doing to them. And you know, it's not just physical activity, it's the wider determinants of health that we think are extremely important. And again, I think we find ways to do things rather than not to do things. I mean, the pros, you know, we're pooling knowledge together. Important to me is keeping the individual at the center of what we're doing. I think sometimes we can quite easily, whether it's complacency or busy lives, we sometimes forget what we're actually trying to achieve, and the individual person comes first, and no one person is like another. So it's expensive, and it takes a lot of resource to help that individual, but the payoff is massive. And you know, what's not to like about that? That's why we're all here, right? So the cons sometimes can be sometimes the technical side, the data, GDPR. You know, we know why it's there, and it's there for a good reason, but sometimes when we're trying to share data together between, whether that's NHS or ourselves, we kind of need to have that overlook and bigger picture, I think. But I think times are changing. I do feel that there is a bit of a change, and I think that, you know, we've got to keep that hope that was mentioned earlier, and I think the future is bright. So let's keep going, and it's bringing sessions like this together that help us see the positivity that's been created. You know, let's spread the happiness.
Indeed, thank you. So one last round of questions for all of you from me is really, what advice would you give to other organizations and colleagues trying to implement similar approaches to system change? I'll start from Amrit, if that's okay. Just one quick tip.
Yeah, and I think some of this is about getting the leadership right at the start. And developing partnerships. And I think we learned a great deal from having early conversations and having lots of different conversations. So I think for me, that's the start. I wouldn't go with a recipe already made. I'd go and try and build it together. Okay,
thank you. Jordan?
I think there's really something about like how we hold hope and belief, because actually these things take time, and change takes time, and I think a huge driving force has been having people that were passionate and that really believe that this could make a difference to people's lives, and I think that's been a real driving force to help us get going. And now we've got going, we've got momentum to keep going, which is wonderful.
Thank you. Annette? Oh, sorry, Sonia, you have your hands up. So
I'd say listen. Listen to the people that you're trying to help, or if they can't make themselves heard, support them to be heard, and keep listening.
Thank you. Annette?
Having it written in policy, which I've already done, a big paragraph. So having it written in the integrated care and personal health budget policy, which has just come out and doesn't even mention it, other than being eligible, but how and what and why, and not having a blanket policy on no activities, but having a look at bringing it back to the basics. Yeah, really.
I can see, Carrie Ann, have you got any tips from the community sector?
Sat here listening with my microphone off. Yeah, I think in the community sector, there are so many of us doing amazing things, but it's very fragmented, which is what I found when I was working in the community, which is how I ended up creating Mind Body Balance Academy. So I think my takeaway from starting the business and the CIC is that we need more trailblazers in the community that are just going to take a chance to push things forward, because there's a lot of brilliant people doing brilliant things, but we need to all work together so much more, and we can do it. You know, it is doable. It's just connection and making sure that we lean on each other to provide the services. I mean, we're all here today, aren't we? And we're all on the same page. So it's just making sure that we have maybe a better network to link up. But Active Cheshire obviously does a brilliant job with sending things to, yeah, you do. So, but yeah, just to work together, I think is the most important thing, and be brave. Yeah.
Thank you. Amrit?
Sorry, there's a number of questions around the funding. So I thought if I just really quickly cover that. So I think the questions were about where the funding came from and how, I suppose that this wasn't additional funding from the ICB. So as a team, we decided that some of the funding we had for practitioners, we're going to use for healthy lifestyle coaches. So I suppose as a team, we had a choice to use it for, I suppose, more of what we have or something different. So, and in terms of opportunities, there's still a huge amount of work around transformation. Roberta has been involved with some of the bids we've made around neighborhood 24/7 pilots. So that's going to happen in the next. This discussion is going to happen in the next few months to a year. And I think there's a real opportunity then to actually think differently and think more holistically. So yeah, there wasn't any additional funding. It was just it's part of the team budget.
It's part of the leadership and the vision, I think. Thank you. Mike, I saw you popped up on my screen. Any comments, any questions from the chat?
Yeah, so there was, excuse me, there was a couple of questions around the funding eligibility, and there was an interesting one about how the HELs were actually recruited and sort of what case was made in terms of the budget holders and how that went about, because we know within system working that's quite a difficult thing. So that's quite interesting. And then there was a comment a bit further down from Danny talking about what didn't go well. So I know we're literally 1 or 2 minutes from the end, but that if we can share some of those things and that learning, again, that's really good for the system to know about that. But I'll hand it back to you, Roberta, because I know we're nearly at time.
It's okay. Oh, Amrit, if you have a quick answer for what didn't go well.
I think we learned along the way. So we didn't have a model where we started off, and I think we learned along the way. I think some things we thought would work in a particular way didn't. So I think it wasn't that they didn't go wrong, but I think it's probably something we had to build, and we had to. So Roberta will remember when we started off, it was actually really hard to get it going. I think to get the members embedded. We found it hard to recruit too, because actually it was completely what we were asking for was very different from what other mental health teams are asking for. So I think those were some of the challenges. But I mean, again, if people, if we can, we have to have conversations outside to sort of look at the details of that learning that came through.
Okay, that's great. Yeah, thank you. And for me, really, the biggest learning has been be patient, learn that the NHS works at a very different pace than anything else. And us as a charity are very dynamic and very reactive. So I think I've learned a lot through this collaboration about how to stop, think, and be patient. I think we have 1 minute till the end. I just want to say thank you for all of you for being here, both the participant and more than anything, the speakers and the service user. I just wanted to finish with maybe 3 points that for me are really important. The first one is, remember that movement is not a luxury, it's a right. We need to do all we can to make sure that everyone has access to movement particularly those who have fewer opportunities to be active. The system work is essential. We heard it here. There's so much happening, but we can't carry on working in silo. Let's, pull together, work together, and do things that make a real difference, like changing policies so that physical activity is part of what we do, of pathways. We don't have to always push for it to be embedded. And finally, the moment is now. The NHS have written it. The NHS England, before they disappear, have written it on the website. The physical activity needs to be embedded in pathways. It is a priority. So let's use the momentum to push in the right direction. So that's my 3 words of wisdoms for today. Huge thanks to all of you. For those who've stayed till the end, you will all receive the recording and the slides and the contacts of the speakers. So thank you very much. And now get up and go for a walk after sitting down for 90 minutes. Thank you.